Apart from the voltage criteria, you may also have picked out the striking changes in the ST segments and T waves present on this ECG. Notice how the T waves in the left-sided chest leads are inverted below the isoelectric line. Also, if you look closely, you can see that these T wave changes are accompanied by alterations to the ST segments. In the left-sided chest leads, illustrated here in V6, you can see that the ST segment is depressed below the isoelectric line, while in the right-sided chest leads, the ST segment is elevated. In the setting of LVH, these ST segment and T wave changes are referred to as an LV strain pattern. The LV strain pattern is an important ECG abnormality, seen in a proportion of cases of left ventricular hypertrophy. We will take a moment to explain the generation of this ECG pattern, as it is very important clinically for reasons we will come back to. To do this, we will look at the heart in horizontal section and examine electrical events in that portion of left ventricular myocardium lying directly under lead V6. As explained in video 2 of section 1, depolarization begins in the endocardium and spreads outwards to the epicardial surface of the heart. Depolarization moving towards V6 produces an R wave, and the peak of the R wave represents the moment when the depolarizing wave has reached the epicardial surface of the ventricle. You will remember that unlike depolarization, ventricular repolarization is not propagated between cardiac myocytes. Cardiac myocytes repolarize at their own intrinsic rate. However, there is a gradient across the ventricular wall in the intrinsic rate at which cardiac myocytes repolarize, with cells at the epicardial surface repolarizing rapidly, while cells repolarize more slowly as we move towards the endocardium. The net effect of this gradient is a progression of repolarization across the wall, moving in the opposite direction to the depolarization wave. As repolarization is moving away from the lead, a positive T wave is produced in V6. This is the normal situation in the left-sided chest leads. Left ventricular depolarization and repolarization moving in opposite directions in the ventricular wall, producing concordant QRS complexes and T waves in these leads. Now let's look at what happens in the thickened wall of left ventricular hypertrophy. Again, we will analyze events in that section of the LV wall directly underlying lead V6. In the presence of hypertrophy, depolarization begins as normal in the endocardial region. But as the ventricular wall is thickened, the wave takes longer to reach the epicardium. Prolonged transit of the wave across the ventricular wall will manifest on the ECG readout as an increase in the time from the onset of the QRS complex to the peak of the R wave. This period is known as the ventricular activation time, and prolongation of the ventricular activation time impacts on repolarization. To understand how, we need to look at the complete sequence of electrical events under V6. As shown here, with prolonged transit of the depolarization wave across the thickened wall, a situation may arise whereby the endocardial cells have reached their intrinsic repolarization time and have started to repolarize before the epicardium has depolarized. The epicardium will repolarize as normal once the depolarization wave reaches it, but you will notice that the sequence of ventricular repolarization has reversed. Repolarization is now moving in the same direction as the depolarization wave, from endocardium to epicardium. And as it is moving towards lead V6, the T waves become negative in this lead. You will also appreciate that relative to the peak of the depolarization wave, repolarization is occurring early, manifesting as a negative deflection during the ST segment. In the example shown here, lead V6 demonstrates several important ECG changes seen in the lateral leads in association with hypertrophy. High amplitude R waves, prolongation of the ventricular activation time, loss of concordance between the QRS complexes and the T waves, and ST segment changes. Note, however, that even with prolongation of the ventricular activation time, the total QRS complex duration remains within the normal limit of 3 small squares in the presence of hypertrophy. This is important for several reasons to be discussed in future sections. Finally, you should also note that as the right-sided chest leads record events in the left ventricular wall from the opposite perspective to that of the left-sided leads, the right-sided chest leads may, as illustrated here, demonstrate deep S waves and ST segment elevation in the presence of LVH. The ST changes of the strain pattern are seen only in a proportion of patients with LVH and may identify a subgroup with a more severe degree of hypertrophy. The key point is that they are chronic changes and are not due to acute coronary artery thrombosis. They are easily confused with the ECG changes of infarction or ischemia, and misdiagnosis can have catastrophic consequences for the patient. There is one further point of interest on this ECG. Looking at the frontal leads, with the QRS complex in AVF near isoelectric, the cardiac axis lies approximately at 90 degrees relative to this lead, giving us 2 options for the axis, one travelling towards the left and one towards the right. With AVL strongly positive and AVR negative, it must be option 1. So, on this ECG, the cardiac axis lies close to lead 1, towards the left but still within the normal range. It does not lie beyond AVL in left axis deviation territory. Remember, the majority of cases of LVH, irrespective of severity, are not associated with left axis deviation, and the majority of cases of left axis deviation are secondary to conduction defects and not left ventricular hypertrophy. We will now go on in the next video to discuss the ECG changes associated with right ventricular hypertrophy.